Hello, and welcome to the Supporting Congestive Heart Failure Patients in the Home Setting through a Comprehensive Community Approach conference call. My name is Michelle, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, you may press star, then 1 on your touch-tone phone. I will now turn the call over to Mr. Ross Gatsky. Sir, you may begin.
Thank you, Michelle. Good morning, everyone. My name is Ross Gatsky, and I'd like to welcome you to today's webinar, Supporting Congestive Heart Failure Patients in the Home Setting through a Comprehensive Community Approach, presented by the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of 3 organizations: Emperor, Michigan, Telehealth in Minnesota, and Metastar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. We know that you and your organization are working hard to improve healthcare quality, support the culture of safety, and improve outcomes for patients with congestive heart failure. We hope that what you learned today will help you to all be successful in these efforts. The session is being recorded and will be available in about 2 weeks. The PowerPoint presentation is a WebEx handout, and the handout information will be available in the chat box as well. We will remind you how to access the handout and a recording at the end of the session. Once again, all lines have been muted during the webinar. However, we will have time for a questions and answers session after the presentation. So please be fully present and engaged, and make note of any questions that you may have as you listen. Also, feel free to share your thoughts in the chat box. And since we are offering continuing education credits, we need to inform you that no commercial support has been received for this learning activity. The speakers have reported no conflicts of interest, and there are no planned conflicts of interest. And for CE credits or certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive. We encourage everyone to complete the evaluation to provide feedback to the session. And once again, I will let you know of the steps of how to complete the evaluation after Diane's presentation. And with that, we are pleased to have Diane Hsu with us today. Diane is the manager of case management for Aurora Sheboygan Memorial Medical Center, which is a mid-sized hospital that is part of the Aurora healthcare system in Wisconsin. She holds a BSN that she received from Marian College of Fond du Lac. Her current accountabilities include oversight of nurse, case managers, and social workers in the areas of med-surg, obstetrics, cardiac, orthopedic, vascular, behavioral health, and the emergency department. Diane has a diverse clinical background in nursing, including medical, surgical, and cardiac nursing, hospital-wide nursing, supervision, and case management. Diane is active in the community as a member of the Sheboygan County Dementia Care Network and a steering committee member of the Sheboygan County Coordination of Care Coalition. I will now turn the presentation over to Diane.
Hello. I wanted to go on to the next objectives, the slide. Okay, so the objectives for today are to articulate the challenges of addressing complex heart failure patients' needs in the home setting, to identify the benefits of forming strong community partnerships to support heart failure patients, and to review our organization's 3-part strategy of home health, Meals on Wheels, and patient education. When we look at our population here at a county level, Sheboygan County in the 2015 census had a population of 115,569. And when we look at specifically congestive heart failure readmissions within our area, the state of Wisconsin had a readmission rate for failure patients of 21.47%. In our Sheboygan County, our heart failure readmission rate was 16%. And this is actually from the Medicare fee-for-service beneficiaries only. So it does not capture the additional Medicare, HMOs, and the commercial patients. And as you heard Ross say, we are a smaller hospital located on the western side of Lake Michigan. So for those of you who want to see where we're at, we're basically halfway between Green Bay and Milwaukee. And there are two hospitals in our community, one of which is Aurora. As far as our hospital-specific statistics, annually, based on the 2016 stats, we had over 20,800 visits to our emergency department. So that's all patients, all diagnoses. And annually, our admissions, both capturing inpatient and observations, was over 6,500. The majority of our inpatient discharges go to home and to home health care, and that's running at about 80% of our discharges. So when we look at specifically our congestive heart failure patients here at our hospital, in the last 12 months, we've had 144 heart failure patients. With our hospital specifically, our readmission rate is running 11.1%, but this is with all payers, not just the Medicare fee-for-service payers. We also look at our congestive heart failure mortality rate, which is running 0.7%, and again, that's all payers. And our average length of stay is 3.19 days. When we look at congestive heart failures, we're always making sure that it's important to weigh the risk of readmission against the length of stay so that we don't necessarily have one negatively impacting the other. When we looked at our congestive heart failure patients, we did a bit of a needs assessment. We realized that we have a fairly significant population of congestive heart failure patients, and we know that CMS, this is one of the populations that they monitor for quality outcomes. So we asked one of our nurse practitioners at our clinic cardiology department a little bit of information about what they're seeing with congestive heart failure. She was actually amazed at the lack of understanding by patients and families about congestive heart failure. And this occurs even when the patient's admitted in the hospital, and we've done our congestive heart failure teaching. We have an educator who does that. Still, patients really didn't understand. We realize that patients, when they are in the hospital, are probably not very able, if you want to call it that, to receive a lot and retain a lot of information because they're really getting information overload during a time that they're acutely ill. The nurse practitioner found that many patients didn't understand that heart failure is really a lifelong disease. They thought that it was fixed by the time they left the hospital. And they didn't know that it could come back or that really is something that they need to manage forever. We realized in our assessment that, that the fact that it's a chronic disease needed to be focused, so that we can't cure it, but there is a focus on support so that they can manage this disease over the remainder of their lifetime. We looked at our palliative care services, and we realized, too, that literature shows that patients can actually live longer, oftentimes, when they have palliative care because they have that better level of support. We know that palliative care is great for chronic diseases. Our palliative care program here at Aurora involves a nurse practitioner and a physician at our clinic. They do come in, they can refer patients and see them in the hospital, but then the majority, or the bulk of their work is really done in a home setting as they're following these patients and continuing to help them find ways to better support themselves. We knew that we needed to look at our readmission prevention tactics and maybe try to think out of the box a bit. Our current practice that we were doing with looking at readmissions was in our Quality Outcomes Committee meetings. In those meetings, we reviewed all of the readmission and mortality cases that were CMS fallouts. So not only for heart failure, but for MI and stroke and hip and knee, those kinds of things as well. Our Outcomes Committee then really looked at partnering and collaborating with hospitalists, the ED physicians, home care and hospice patients, or staff, I should say, the palliative program, even our Vince Lombardi Cancer Center, because we see a fair amount of oncology patients as well. And we have, within the last year, really added our clinic, our outpatient clinic as well. We have a very large theater clinic here in Sheboygan that is full of Aurora physicians that are primary care providers as well as specialists. So by having all of those at the table, we thought we'd get the best use of everyone's interdisciplinary and interagency feedback to look at better ways to prevent readmissions. We also, of course, look at mortality prevention as we're looking at the readmissions because we want to be able to support the patient as best we can through that disease. But I think our key factor that we found is that the majority of our patients really do discharge to that home setting. So this needed to be really the focus of our efforts to make an impact. So when we look at the home setting, to me that means, where do they live? Where does the person call their home? It may be an apartment, maybe a house, maybe a mobile home, or an assisted living facility. It doesn't matter the location so much as the fact that this is home for them. And when we think of patients at home, we need to talk about the type of support from their family and friends. And we all know that that can vary. So when we look at that, there's a few factors to consider into this support that is from, again, family and friends. One of them is the proximity. So if the person is living maybe with their granddaughter upstairs, and forgive me, I'm going to use the word patient all the time, where I know that they're not always a patient when they're not in hospital, but so our patient might live downstairs and the granddaughter lives upstairs. Or you might have it that the family lives in town, perhaps out of town, maybe even out of state. So proximity can make a difference. They're not there all the time. The degree of their proximity certainly can affect their supervision or their management of the patient who has the heart failure. And that could be in things such as, maybe meals. Do they do the cooking or the shopping for the person who has heart failure? It could also be related to the supervision of medications. Do they pick up the medications? Do they set them up as in like a pill box? Do they actually administer those? And another level of supervision or management is what I call eyes on the patient. It's really just an assessment, even though they're not a professional. They're the family member or the friend who sees them all the time, who knows, gee, they seem a little bit more fatigued today, or they have more shortness of breath or more edema. So those are the kinds of things that they can do for some watching for assessing. We know that family dynamics or even the dynamics of a friendship can make a difference too as far as the level of support. We can go from a very healthy family situation to a very dysfunctional family. So that all has an impact. And I just wanted to mention the assisted living as their home setting, and to basically focus on the fact that typically that is staffed with non-skilled caregivers. There is no nurse who's there 24/7 like you'd have in a nursing home. Some of the facilities are staffed with CNAs, but not all. And they may have, so if they're not a nurse or a CNA, they might just have some on-the-job training, or maybe they've taken a MedPass course, something on that line. So you're really not having these skilled nursing assessments. The people that are working at that facility and caring for heart failure patients may have a very minimal knowledge of the signs and symptoms to watch for heart failure, or really for any other chronic disease as well. As far as the challenges that we have with heart failure patients in the home setting, I think one of the big ones is the fact it's the scale. It really is more than just owning a scale, though. We have to know first, if they have one, do they know how to read it? Oftentimes, the old scales have that little dial, or gauge that would go up and down when you stepped on it. The new electronic ones, sometimes you have to tap on it, it goes to 0, then you step on it. So there's the different ways of, actually stepping on it to get an accurate reading. Do they know how often they should take their weight? Do they know what it means? And by that I mean, do they even have an idea of what their baseline weight is or their goal weight is? And do they know when to even think about worrying when their weight goes up, or worrying about when to call the doctor? So those are just some of the things. So just having the scale isn't enough. They have to really understand its use. Challenges for reading labels. It can be like alphabet soup for some of the patients to understand what's on a label. There's not really a way of knowing if they haven't been taught and understood this. They look at what's on a label and they may not know what the sodium value is or what it even means. Many people don't know that the highest ingredient is listed first in the list of ingredients, so it can be very challenging to them. Cooking can be another challenge. It's really important to know who is the cook, because the same amount of teaching that you give the patient should be given to the cook as well, because if they're not understanding the impact of how they're cooking with the salt and things that way, then they can make a very detrimental impact on the congestive heart failure patient. We look at during the summertime when fruits and vegetables are plentiful, oftentimes it's not a problem for patients to have good, fresh, nutritious foods. However, when they're off-season, it's more expensive, then they might not be able to afford those foods. They also may go toward more processed foods. Your canned lunch meats and your canned soups, things like that are, of course, higher in sodium. Dining out, too, can be a challenge. First of all, for the food selection, how do they make the right choice to what's better for them in their diet, as well as when they go to a fast food or even to a fine dining, a lot of the menus don't have nutritional information. So they can't rely on that to even help them. If they understood a label on something, they might be able to benefit from that. But if the menu doesn't give them any nutritional information, it can be challenging. More and more of the fast foods are putting some nutritional information on their on their menu selection, but a lot of that has to do more with calories and maybe not so much with the sodium intake and things that way. Of interest here in Sheboygan, we kind of have some local favorites: Sheboygan brats and cheese. And that's because we have Johnsonville sausage in our backyard, and our county is known for having many, many cheese factories. So we have that little additional challenge because our holidays here are oftentimes celebrated with things like brats and cheese. The elderly patients have some additional challenges, and the first one is really the fact that we often don't hear the whole story. Many times a patient will say what they think you want to hear, not necessarily giving you the truth. So it's really important to confirm that reality with the family. You want to actually contact the family, talk with them, and make sure that what the patient is saying is accurate. An example of that might be that the patient might say, "Oh, my daughter," while you're doing your assessment, as the patient's admitted, "Oh, my daughter brings me my meds, and she does my she does my medications, she brings me my meals, she even does the grocery shopping for me." So she's saying, "No, I won't need anything. I'll be fine when I get home. Doesn't need any services." You contact the daughter, who might say, "Well, in reality, she brings her 3 meals a week, but often the patient doesn't eat them. She prefers her little canned soup or her lunch meat, that kind of thing, a sandwich, because it's easier to fix, and she doesn't have to use the stove." And then when you ask her about medications, the daughter says she just picks them up from the pharmacy. Mom's too stubborn to have her do a med box, and of course Mom administers her own meds. And the daughter says that at times the bottles are still like nearly half full. So you really can see in this example that it's not necessarily what the patient tells you is the whole truth. What we see in Sheboygan is a fear of someone coming into their home. When we're asking patients and trying to promote some use of maybe, say, home health care to come in, they're often saying that, no, they don't want that service. They don't want that. And as we dive down into things a little bit, we find that there's a couple fears that are going on here. One is for someone coming to their home is they're really feeling like if someone comes in and sees how they live, they might find out that they really can't manage and then make them leave. So it's the fear of being forced out of their home. Sometimes people are hiding poor living conditions. It might even be a hoarding situation. And so they're embarrassed. They don't want to be judged. So they just refuse anybody coming into the home. Even though they probably inside know that they need that assistance, they're just too afraid. And other times they fear stealing or dishonest persons. There's a suspicion or very fearful of maybe their own personal safety. So this fear can be a challenge that we have to work through with the elderly. I wanted to share just maybe a common patient scenario of a heart failure patient. We've got an 83-year-old female, got a history of failure, diabetes, hypertension, living alone in her low-income apartment. Family's out of town, and when they do come and visit, they want to do a little treat, so they bring her fast food item. She doesn't cook much. She eats mostly those canned soups and the sandwiches with some lunch meat. And in fact, she's even self-adjusted her diuretic to maybe taking it every other day because it saves her a little bit of money, and she really doesn't like going to the bathroom that often. It kind of interferes with her social life or her, just her ability to do what she wants during the day. So I'd like you just to kind of keep this patient in mind, and we'll come back to her later on. Our approach is that really the hospital cannot succeed alone. It truly does take a village. And in our community, we partnered then with Home Health Care, with Meals on Wheels, and the Sheboygan County Coordination of Care Coalition. So we're going to talk about those three entities. However, before we do that, I thought that we could talk about the tools in our congestive heart failure toolbox that we are currently using. The first one is the LACE score. And for those of you that are not familiar with that, I'll give you a little bit of information. It's a tool that is used to measure readmission risk. So the L stands for length of stay, and if you get a score assigned to you that on your admission day, and each day, if you're there another day and another day, your score would increase. So L is for length of stay. A is for the acuity of the admission. It takes into account whether you entered through the emergency department or not. The C is for comorbidities, and it's not that each comorbidity gets a score. They're put into a table, and a rounding score is added in. And then the E stands for emergency department visits that you've had in the past 6 months. So it gives you credit for that. So those are all tabulated. We currently have it auto-calculating in our EPIC electronic healthcare record. So a low rate LACE score is 0 to 4, a medium is 5 to 9, and a high risk is greater than 9. So again, this is a readmission risk factor. And we then will take this LACE score and focus on that in our OFTs. You can see OFTs is the second tool listed there. OFTs stands for Outcome Facilitation Team. These are meetings that we have of an interdisciplinary team. They're held every Monday through Friday. And our team includes the discharge planners, which here at our facility are case managers and social workers. It also consists of physical therapy, our palliative care folks from the clinic, dietary, pharmacy, our cardiac educator, and our chaplain. You might notice from this list of folks that I indicated here that there's a couple missing, some significant ones. That would be the physician and the nurse. What we've done in our site is we have a unique physician-nurse case management rounding with the patients. So every day we will round as a triad at the patient's bedside. That allows the physician to do his little exam of the patient, and for all of the members of the team here to also be able to have conversation, talk about the plan of care, talk about any barriers to discharge, those kinds of things. So we then, case management bring what we've learned from our nursing, physician, and case management rounding back to the table at OFTs and present that information. So we're actually getting the whole big interdisciplinary input at that point in time. We use the OFTs to identify and eliminate discharge barriers. The last tool on this list is ISAR in the ED. And ISAR, for those of you who don't know what it means, stands for Identifying Seniors at Risk. This is a 6-question tool that our nurses in the emergency department give to all patients who are considered elderly, and elderly is defined as 65 or older. So when you ask these 6 questions, if you have a score of 2 or more, it's considered positive. And positive means you're at risk for an adverse outcome. This tool is not specific enough to tell you what adverse outcome, just it is some adverse outcome. So it could be things like a fall, a readmission, or death. The ED staff then uses this ISAR tool score, so if it's positive, they're really focusing on trying to get additional referrals out to patients. And we've chosen in our geriatric, we have a geriatric pilot going on here. We've chosen 4 real main referral sources. That would be to skilled care services of home health or physical therapy, to our outpatient palliative care program, to the ADRC, which is the Aging and Disability Resource Center, also sometimes known as the Office of Aging, and to primary care providers or specialists. We found that many patients don't have a primary care provider, so we're able to link them up with one. What we found with some results with this ISAR in the ED is that with our initial data evaluation after several months of use, is that we were able to bring our readmission rate for patients coming back to the hospital who used a referral. It was 5% less than those who came back to the hospital without a referral. And our most recent data shows a 9% decrease in readmissions for people who had a referral that was completed versus those that did not have a referral. So we're happy that at least we're doing something in that line from the emergency department directly. I thought I'd just share with you real quickly the next two slides. Let's just move the slide here for you. There you go. The 6 questions that are in that ISAR tool. So before the illness or injury that brought you to the ED, did you need someone to help you on a regular basis? In the last 24 hours, have you needed more help than usual? Have you been hospitalized for 1 or more nights during the past 6 months? In general, do you have serious problems with your vision that cannot be corrected with glasses? In general, do you have serious problems with your memory? And do you take 6 or more different medications every day? So again, a score of 2 of these becomes positive for an adverse outcome. And I think that we could probably all agree that it would be fairly easy to have a score of 2 or more. So let's really take a look at our first area of focus, and that's home health care. Here at Aurora, we do have our own home health care service throughout the system, and each site then has the opportunity to have a liaison, and this is a person who is our resource for nursing and for physicians and discharge planners. So although the case manager talks to the patient in general about health care and suggests that maybe that would be something they would want, and we then also are the ones who need to offer choice, we have the liaison who can come in and give a much more in-depth information to the patient. They're able to do what we call an info visit, so they can sit down and really discuss the many things that home care can offer. And we are now trying to, we have some resistance. Our patients don't necessarily want to have home care, and I think for some of those fear items that we talked about just a few moments ago. But we then will say that we'd like the patient to make their final decision after they talk with Lisa, our liaison. On the slide also are some of the other things that home care services can provide. And that would be teaching about the chronic condition so that they realize it's lifelong. They can do med management, whether it be for new medication, adjusting meds, or teaching purpose and side effects of the drug. Definitely they can do weight monitoring and telehealth services. I'll talk a few about that in just a moment, as well as providing some palliative care through home health. Palliative care can lead to hospice, but it really is a separate entity. And our palliative care through home care can support the patient with these chronic conditions, with discussing their goals of care and the type of quality of life they want and whether they want to be readmitted to the hospital, those kinds of things. And what we find with palliative care through home health is that we can actually combine that and also do our outpatient palliative care program. So home health palliative care can stay in the home while there's a skilled need, and then the outpatient clinic palliative can continue on after that and continue to further support the patient. But then when they get a decline and they need skilled care, they can call back in the home health care. So it seems a little unusual, but it is possible to have both palliative care programs involved with the patient. The next slide talks about telehealth and telemonitoring, and it really is much more than the equipment. We know that they come in with their equipment so they can check the patient's vitals and their weight and things that way. But telehealth includes nursing assessment. You have that face-to-face assessment from the skilled nurse who's making her home care visits, but you also have the off-site nursing monitoring. They're able to have a nurse who is interpreting the data from this equipment so that they can then really professionally monitor this patient, and you have that higher level of monitoring and nursing care. Telehealth is actually allowed to stay with the equipment in the home only during the time that there is a skilled nursing services need. And here in Aurora, that's averaging about 47 days. The system and site goal for telehealth is for 25% of all eligible patients to receive the telehealth services. They really are seeing some good benefits of telehealth regarding preventing readmissions. So we want to continue, and they do continue to show very positive results. A year ago, they were doing well with 5 to 8% readmission rate, and currently now with telehealth, it's 3 to 7%. This next slide captures that more in a graphic form. The tall bars are the number of patients on service with telehealth. Now, this is system-wide data in Aurora, but Sheboygan is obviously a part of that value. The bottom numbers across your screen are the number of hospitalizations that the telehealth patients have had, and then the top numbers there in gold are the percent of readmissions for the telehealth monitored patients. Again, you can see it's 3 to 7%. So let's change gears and talk about our second area of focus, which is Meals on Wheels. In Sheboygan County, our Meals on Wheels is a fresh Meals on Wheels. They have their own gardens, do a lot of their own food growth, and they harvest that. They also, of course, rely on donations from businesses and individuals. So our partnering with Meals on Wheels was part of our out-of-the-box thinking for how do we prevent some readmissions. There was an article called Good Food, Good Health that provided some literature review that showed some positive impact on congestive heart failures when you partner with Meals on Wheels. The Southwestern Vermont healthcare system found a decreased incidence of readmissions when they used Meals on Wheels. Their numbers showed 2.7% readmission rate with patients going with Meals on Wheels compared to 8.6% for the overall hospital rate. So the Meals on Wheels leadership approached our hospital to see if we would be interested in looking at a similar program, maybe as a pilot. We knew that there are many factors that can certainly affect and be a variable with congestive heart failure, but the diet, getting on a good cardiac diet, 1 meal a day, would be one variable that we could control. So we pulled together a steering committee that met with the Meals on Wheels leadership, and our steering committee consisted of our outreach, our community outreach department, the dietitians who are involved in helping with referrals as well, our discharge planners, which is our case managers and social workers, so case management department, our quality department and hospital administration, a cardiac educator, and our patient experience coordinator. The pilot itself needed to look at a couple different elements. First of all, we need to look at patient selection. We initially chose primary diagnosis of congestive heart failure, but after a couple months of starting the program, we weren't seeing as many patients as we thought we could be affecting. So we opened it up to patients with a secondary diagnosis of congestive heart failure with an ejection fracture of 35% or less. Our exclusionary criteria were to people that were going to be discharged to a nursing home, but returning to work so they wouldn't be there to receive the meal, and to anyone who just outright was not interested in it. Our discharge planners then identified potential patients for the pilot and offered them the Meals on Wheels, so giving a basic explanation to them about the fact that it would be paid for the hospital and that we would not release their private information, things that way, other than to Meals on Wheels for what information they needed. The program consists of 1 hot meal a day for 30 consecutive days after discharge. Monday through Friday, they get the meal delivered, and then on Fridays, they get their meal for Saturday and Sunday also delivered. They put it in the refrigerator, and they just need to heat it up. Our pilot, though, is more than just the meals. We needed to have some assessment involved. We thought that was very important to make sure that we were keeping an eye on these patients. So we created our Stoplight assessment tool. We really capitalized on the educators' use of a teaching tool that they were already doing here in the hospital. It's really a method to do a little bit of a daily self-assessment of your physical condition. Pilot also relies on an expanded role of a delivery person. Meals on Wheels relies on volunteers to deliver their meals, but we didn't want just somebody to drop the meal off. We wanted them to have a little training so that they could be our eyes on the person. So really what Meals on Wheels decided to do was use some of their leadership for their delivery people initially so that they had some control over how this was going, what was the interaction with the drivers to the patients. So they're actually able to ask the patient, how are they feeling today based on that daily assessment from the Stoplight tool. And then the driver would report back to Meals on Wheels leadership or even refer to the physician if they needed to for any safety or concerns that way. We found the drivers then were actually looking in the refrigerators to see if the patient was eating their food. They'd been attuned to things like normally the patient is up and about and, seeming to be active in their day, and now today they're in their pajamas, and so maybe something's not quite right. So they would start to make some assessments that way. One of the other things we had as far as with the pilot was funding. We knew that would be a challenge because we hadn't budgeted for anything like this in our yearly budget. So we created an SBAR as far as what we thought would be some return on investment with this program, and of course we felt our return on investment would be to decrease our readmissions. So the cost of a meal is $6.15 each day, and it comes to about $185 a person for the pilot. We started our pilot in May of 2016. Next slide here shows the Stoplight tool that we used. Again, I said that this was adapted from what cardiac educators were using. And it really does look like a traffic stoplight with the yellow, green, and red sections. So the green means, I'm on goal. I'm meeting my goals for my heart failure management. The yellow is caution. Be alert to changes. You might want to contact your doctor in 24 hours if things don't improve. And the red is stop, get some help. You need, things are not going well here. Might even have to call 911. So you can look at in the circled areas, the different criteria that we were using. So weight gain of more than 3 pounds in 1 to 2 days, or weight gain of more than 5 pounds in a week. That was more of your yellow category. This is done in a cardstock, very colorful for the patients. They can maybe put it on their refrigerators and have it as a reference, and the family can use it as well. As far as our Meals on Wheels results, May of 2016 through beginning of August this year, 49 patients completed their 30 days post-discharge with Meals on Wheels. Initially, we had a pilot for about 35 patients, but we were able to increase that to more patients and continue to do that now. 6 of those patients were readmitted in their 30-day time frame for reasons of congestive heart failure or COPD. 1 had pulmonary edema, 1 atrial fib, and 1 UTI. That equated to a 12.24% readmission rate. So I want to compare that back to our stats from the beginning of this presentation, compared to the state heart failure readmission rate of 21.47% and the county readmission rate of 16%. Feedback we got from our patients: they loved the program. They felt that they learned what food they can eat on a cardiac diet. They learned portion size. They felt that by having a diet delivered and they didn't have to cook, they were really better off trying to adhere to a diet. They learned to listen to their bodies, pay attention to their weight and their shortness of breath by using that Stoplight Report, and they love the delivery folks. They found them to be friendly, attentive, and really concerned about them and their health. And they even commented that one person even said the dog loves the delivery person even. Many of them have suggested that if we would have a funding cut, that we would at least continue this program for 2 weeks to offer it for a patient, because they felt that 2 weeks is about the time it took for them to start to feel like they were understanding what they needed to eat. Again, they got so much overload in the hospital that they didn't have time to sort through all their paperwork, and this was very helpful to them. And many of them have actually continued the program after the 30-day period of free food and are paying for the program themselves. So the last one I'd like to look at, the strategy, is our community, our coordination coalition that we created. The mission is to improve the quality of care for Medicare beneficiaries who transition among healthcare settings through a comprehensive community effort of improving cross-setting communication, care coordination, and patient-caregiver self-management. The coalition is committed to the CMS goal of reducing hospital readmissions in Medicare program by 20% by the year 2019. How did our coalition get started? Well, Medistar currently has a lot of experience in implementing similar coalitions in many of the different states and in many of the counties in Wisconsin. So Medistar approached the ADRC to see if they might be interested in a partnership to create this coalition. And then the ADRC reached out to the hospitals. As I said earlier, there are 2 hospitals in our community, but the other hospital was, for whatever reason, not able to be an active member in the steering committee. So the 3 of us, Aurora Hospital, the ADRC, and Medistar, then co-lead this coalition. We opened it up to membership to anyone in the county that was a healthcare agency or healthcare related. So we have participants from hospitals, clinics, SNFs, assisted living or CBRF, home care and hospice, pharmacies, physicians, EMS, literally anyone who's interested in the goal of improving the care for the elderly and decreasing readmission. Medistar provides us with a lot of different statistics, basically readmission statistics and things related to diagnosis, destinations, dispositions. We can have them slice and dice the data to provide whatever information we'd like on a county-wide basis. When we all met, we really shared our strengths and the opportunities that we all identified in the county. And one of the first biggest opportunities we felt was education, because we have a lack of that, especially when we look at the heart failure patients. So our initial project was some heart failure patient family education that needed to be a consistent guide for that patient and the families so that they were getting the same message. We're hearing from families that one provider would tell them one thing, one would tell them another, especially having to do with like weight and things that way. So we decided to tackle a low-hanging fruit and adopt our Stoplight Report, which you can see it looks fairly similar. I need to apologize. I have multiple lines in the office, and three times and it will stop. So again, I apologize for that. Okay, so this quick guide then we adopted from our hospital Stoplight Report that we used with the Meals on Wheels pilot. So it's really 2 pages, and we have it in 2 forms. One is that you see now on your screen is our wallet size, so it's a trifold that could be used for the patient. And then I'll show you this next page here. So this is the trifold front and back. The other is really the same type of information, just in a larger version. So it would be a full-size sheet of paper divided into thirds that we thought the family could use, or maybe put on the refrigerator or something like that. And it had a few more of the signs and symptoms listed on it. The other thing that we added to this quick guide is the statement that it's through the coalition, so they know where is this coming from, because we're not allowing any other branding other than the coalition name on there. And with a reference number of contacts, so if they wanted to ask questions or if they wanted additional copies of this, they would know who to contact. So what are some of the challenges that were faced by the coalition in implementing this heart failure quick guide? You know, we thought it was a low-lying fruit, but we really found out it has its challenges as well. Disseminating the information was a challenge because we had to identify or disseminate the information about the quick guide as well as the coalition, because our coalition has only been in existence for about a year. Members volunteered to share this with their agency, and then even others that they knew, other outside agencies, to just keep spreading the word. So we needed to educate providers and agencies so that they understood the quick guide and that they could explain it to families. So I created a cover sheet that was educational about that. Cost of printing was also a huge challenge because the coalition has no funding. Metastar graciously printed out the first 250 copies, and then each of us steering committee facilities have done some printing as well. Since then, we now have a new website that's been created for the coalition. One of our physicians created that, and someone else in the committee is maintaining that. So all of our files, including the ability to print this document, will be on that website. Crossing the political line of different agencies was kind of a sensitive issue as well. You know, everybody has their own branding. So we realized in the coalition that everyone needed the information, but are they willing to accept it? So all we can do is provide the information with the explanation and hope that they will use it. The other thing to determine was how to figure out if we were effective in using this at all. We can't really track everybody who gets the guide, so we need to watch the county readmission rates over time. So we need to, since this is very new to our implementation, we will be watching that and seeing, hopefully, that we were effective. And it's difficult to keep members engaged because it's such a widespread agencies that come together, and not everybody's available every month to come to a meeting. So we try to revisit our topic at the monthly meetings and share emails and things in between. And then while we're still, really fine-tuning this whole dissemination of the heart failure tool, we're looking at our next topic to focus on as well. And for us, that's going to be transportation of wheelchair-bound patients after hours. So with our coalition being new, we needed to realize that this is really a marathon. It's not a sprint. It's a process over time, and it's a work in progress. So we're hoping that our data over the next several months to a year will show that we've had some impact on congestive heart failure with the use of our quick guide. So if you remember our patient that we had earlier, I won't read it again, but if we think of this patient, the heart failure patient, I want to now take a look at that and look at how this same patient could have been impacted by our 3 different community agencies or strategies. So with Meals on Wheels, they were provided dietary support, some education on their portion size and the right foods for a cardiac diet, provided some socialization with a delivery person and follow-up calls. They got an actual set of eyes on the patient because that delivery person was going to do a little bit of an assessment and find out how they were doing medically. Many times they've now, adhered to their diet, and sometimes they'll continue with Meals on Wheels just because they liked it so much. Home health care, the impact that they could have on our patients would be disease education, reinforcing the fact that it is a chronic disease and they have to manage it for the rest of their life, nursing assessments, medication management and teaching, education about sodium and how to read labels and menus, to have the telehealth services while the skilled nursing need existed in the home, educate on the use of a scale or even provide them a scale if they didn't own one. They'd be connected with the palliative care services for that better support and really looking at their goals of care, and connected with a financial counselor who could link them to a drug assistance program so that they could then afford their meds and have an increased chance of compliance with taking her diuretics the correct way. The impact that we have with Sheboygan County Coalition is that the patient and the family have the heart guide, their quick guide, as a reference, so everyone is on the same page. It's that consistent messaging. And the patient is then able to understand the importance of monitoring daily weights and listening to her body by using the quick guide. And then a future benefit is they might benefit from other initiatives that the coalition comes up with in the future. So in conclusion, we need to look at the next steps. We realize that congestive heart failure patients often have complex medical conditions due to multiple comorbidities. There's really a need for someone to help them outside the hospital to navigate that healthcare system. So we're seeking a community-based case management social work position here at our hospital to work with the patient through the healthcare maze. So our journey here at Aurora Sheboygan Memorial Medical Center continues as we strive for better ways to help CHF patients live well, because this is the mission of Aurora. I would now take any questions.
Thank you so much, Diane. That was great. And we also wanted to mention that Diane has been an invaluable member with our coalition work in Sheboygan County. So we really appreciate her coming on today, spending all the time preparing the slides and providing us with this excellent content. It is greatly appreciated. I also did want to mention, and I apologize, I should have mentioned this at the onset of the webinar, that this webinar is a part of a four-part series, which is presented in a collaborative effort between the Lake Superior Quality Innovation Network and the Great Plains Quality Innovation Network, which also includes the states of North Dakota, South Dakota, Nebraska, and Kansas. So since heart failure is a top readmission diagnosis for patients in all of our states, we are focusing a webinar series on the heart failure, and like I mentioned, this is the fourth webinar of the series. And I did provide the link to the other three webinars with the recordings and the slides in the chat. And with that, Michelle, I think you could open up for questions.
Thank you, sir. We will now begin the question and answer session via audio. If you have a question, please press star then 1 on your touchtone phone. If you wish to be removed from the queue, you may press the pound sign or the hash key. There will be a delay before the first question is announced, and if you're using a speakerphone, you may need to pick up on your handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touchtone phone. We're standing by for questions, sir.
Okay, thank you. I guess while we wait for some questions to come in, questions or comments, feel free. This is kind of an open sharing session. Diane, I guess you mentioned about implementing some of these projects based around CHF patients. I guess how was it, in deploying these strategies within members at your hospital? How did you get some of the buy-in based around putting more work in more of an intensive approach with this patient population?
Sure, I can answer that. Here at Memorial, our case management department reports directly to the quality department, so I report to the quality director. And so you know that the quality department is always looking at statistics and ways to prevent readmissions. So that was a good alignment, and having anything that we can do, we're always looking at it to be proactive. Sheboygan is a very competitive, our culture is to be competitive, to be proactive. We don't want to be reactive. So we want to look at if there's a way out there to do something better, we want to be first at it. So when Meals on Wheels threw this out there, of course we wanted to do that. So we found a way in our site to go through the quality department, get that blessing, who could then get it through leadership and say, yes, even though it's not budgeted, we really feel that there is an impact that could be done here, and we went ahead with it.
Okay, great. So it's like it's a collaborative effort between the different levels in your department. It really
absolutely
comes down to that, because you do need the blessing from the higher ups, but at the same time you need the worker bees to implement it. So okay.
Correct.
Thank you. And Jennifer, I'm sorry, I keep calling you Michelle. Do we are there any questions in queue?
I do have one question in the queue from Laura Dewberry. Ma'am, your line is open.
Hi, good morning, everyone. My name is Laura. I'm from Molina Healthcare in Tri-County. I was calling to see if we wanted to make a referral for your program. How will we do so at Memorial in Sheboygan?
A referral for which of the programs?
The congestive heart failure program. And so just kind of having some resources available for patients with CHF, if we wanted to refer them to you for case management or whatnot, how will we do that?
We connect them with home care, and we do the Meals on Wheels for patients who are here currently in our hospital discharged from that.
Okay.
So it's not like we're taking patients from the outside as another referral. So this is our internal patient.
Okay.
Connecting. Other than the coalition is for anyone in the county, and then we can provide information on that quick guide.
Okay, sure. So if a patient has congestive heart failure, you automatically go through that process with them when they are admitted to the hospital?
Yes, we're definitely offering the home health. We are giving them the opportunity to be a part of our Meals on Wheels pilot as well.
Okay, thank you so much.
Yes. Any other questions?
No, there are no other questions in the queue at this time, ma'am.
Okay, we'll give it another minute or so, because we are running up against the end of the hour, and we want to be respectful of everyone's time. I also did want to mention that there is for those of you who will receive continuing education credits, in the chat box I have provided the link to the continuing education survey that you complete to receive those credits. You will also be automatically routed to the evaluation, the CE evaluation. Once you close out of this window, it'll direct you directly into the evaluation. So I just provided the link just in case you are not automatically directed. And Michelle, has anyone else queued in for questions or comments?
No, sir. We have no other questions at this time, sir.
Okay. Well, I guess with that, we can end just a couple minutes early. Once again, thank you so much to Diane Shu for sharing all of her great work that she's doing with Aurora Sheboygan. We really appreciate your time.
You're very welcome.
Thank you. And with that, this concludes today's educational session. Remember that the PowerPoint presentation is a WebEx handout, and I have provided the links within the chat box as well. And also the recorded presentation will also be available on our YouTube page. So you can go to YouTube and just type in LSQIN, and that will direct you to our site. And usually the recordings are available within a couple weeks after the live event. So once again, please take a moment to complete the evaluation once you leave the WebEx presentation, and provide your feedback to help us continue to make these quality events. Thank you so much for spending your time with us today.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.